This podcast is sponsored by Pfizer. At Pfizer, we believe collaboration is essential for advancing the treatment of chronic immunoinflammatory diseases. Through research and education, we remain dedicated to supporting the healthcare community to improve the lives of those impacted by rheumatic diseases. To find out more about our commitment, visit Pfizer.com. And don't miss our Innovation Theater at ACR Convergence, presented by Dr. Christina Charles Showman on October 26th at 2 p.m.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. We live in an age of extraordinary medical precision. Our pharmacologic toolbox is deeper, sharper, and more targeted than ever. But as Barbara Slusher reminds us, what's often missing in rheumatology and in medicine more broadly isn't just another drug. It's recognition of grief that has no funeral, of depression that hides behind joint counts, of patients who mourn the futures they had imagined for themselves before they became ill. This conversation isn't about rejecting medications. It's about what happens when we flip the script, when we stop thinking of the prescription pad as our only tool and start listening to what our patients have already lost. So today, we talk about disenfranchised grief, the biochemistry of depression and inflammation, and the power of teaching our patients and ourselves to heal in ways that no pill can do for us. This episode is part of a special series of conversations airing during ACR Convergence 2025 in Chicago, where we're highlighting just a few of the novel ideas being presented at this year's meeting. Barbara Slusher is a physician associate with Hope Health, a federally qualified health center serving rural communities in Manning, South Carolina. She earned her PA degree from the University of North Texas Health Science Center, College of Osteopathic Medicine, and she holds a Master of Social Work from the University of Maryland in Baltimore. In 2024, she became board certified in lifestyle medicine. She's also a distinguished fellow of the American Academy of Physician Assistants and an active volunteer and past executive leader with the Associations of Rheumatology Professionals. Enjoy. Barb, welcome to the show.
Thanks, John.
We're going to be talking today about sort of other things that we can do to help our patients that are not medications. And you have this really interesting talk about sort of grief, depression, anxiety in patients with rheumatic and musculoskeletal diseases. I was wondering if we could start a little bit just discussing the extent of the problem. What do we know about rates of depression among patients with rheumatic and musculoskeletal diseases?
Thanks, John. It's really surprising. So hold on to your hat, because multiple studies document that depression and anxiety are more common, almost 2 times more common in chronic autoimmune disease. To that end, a large UK cohort study of 1.5 million people found lifetime affective disorders, including depression, bipolar disorder, anxiety, were 28.8% more likely in autoimmune disease versus 17.9% in the general population. So that roughly calculates to 2 times the risk, even after adjusting for demographics, pain, and social factors. And this comes from the Lutz article.
That's crazy. And why do you think that is?
I think there's a complex interplay, and we can kind of talk about it later on, about the overlap of some of the biomarkers such as C-reactive protein, IL-6, TNF-alpha, IL-1. And it's not only with just our rheumatic and musculoskeletal diseases, it's also in other chronic inflammatory conditions to include multiple sclerosis, Graves' disease, Hashimoto's thyroiditis. So it's not unique to our diseases.
I mean, it's wild because, on the one hand, you could say, well, patients are bummed because they have this chronic autoimmune disease and that's why they're depressed. But I guess what you're hinting at is that there may be some additional biological systems that could be contributing to mental health issues
Yeah.
in the patients that we serve.
And I think adding weight to this statistic is the recently published ACR guideline statements addressing mental health conditions and youth with pediatric rheumatic diseases. They highlight the patient and family centered approaches should really be standard and the importance of early identification. So we're not only just seeing it in adults, but we also are now, discovering and understanding how important it is even in the pediatric population.
Absolutely. Actually, just yesterday, I saw a patient, a teenager with lupus, with one of my fellows, whose lupus had been quiescent for the last 2 years, but her main issue is depression. So, yeah, definitely brings it home. And the other thing that you discuss in your talk is about this term that I've actually never heard before, which is disenfranchised grief among patients with rheumatic and musculoskeletal diseases. Usually I think of grief, in patient when people have had a loss of a loved one in general. But what do you mean by disenfranchised grief among our patients?
You're correct, because typically grief is defined as a deep sorrow, especially that caused by someone's death. But grief experienced by patients with RMDs or even chronic disease is unique. It's kind of an invisible grief. It's not
Hmm.
the typical bereavement related to death of a significant other. It's more the grieving of the loss of a future, the loss of function, the loss of physical capacity, the death of a career, the death
Hmm.
of travel, the death of hope of having a family. And even in pediatrics, think about it from the standpoint of the loss of childhood. Their life becomes focused on medical appointments, treatments, medication side effects. So the disenfranchised grief reflects this unique type of grief that's often unrecognized. People that experience it are really denied their right to grieve openly and to receive social validation for their loss. So, for example, you're not going to send a condolence card for the inability to hike or losing the ability to drive a manual stick shift car or not being able to participate in a sport. So that's what we mean by disenfranchised.
Yeah, I mean that makes a lot of sense. I've never really thought about it that way. That people sort of, I guess, they're grieving also the loss of their previous identity, right? Like, I
Correct.
am a healthy person, and now I am somebody with a chronic autoimmune or inflammatory disease. And I guess, like you said, that can certainly profoundly affect a patient's outlook and how they see the world, how they see themselves. And certainly there can be a lot of huge impact in their
Well,
psychosocial functioning.
I don't want to miss the opportunity to say how important it is for us as providers, especially you being a pediatric rheumatologist. You have probably fantastic relationships with your patients, as adult rheumatologists do too. We're often very trusted. And just listening or just stopping and taking a moment to recognize that grief or that loss, whatever it may be for that patient, is oftentimes very healing. And that's one of the first things that I would like to emphasize, that it's important for us to just take a moment and think from our patient's perspective, a little bit of empathy.
I love it. I think oftentimes we focus on the medications and we forget sort of the person behind the medications. So you hinted at it before, but sort of this idea of the relationship between inflammation and mood and depression. Talk a little bit more about what we know about that subject.
I think it's a great question, because you have to ask, is there a link between these affective disorders like depression and anxiety and chronic inflammation or even inflammatory arthritis? When I first started working in rheumatology in 2006, I was aware of the greater burden of depression amongst patients with RMDs. Prior to my other outpatient practices, I saw
Hmm,
more depression. I
hmm.
even had several patients who asked me, is depression part of my arthritis? And back then, we didn't really know. I would just ponder the question and say, we don't really know what comes first, the chicken or the egg. So I think now we have more data that corroborates the overlap of pro inflammatory cytokines involved in the pathogenesis of autoimmune conditions and depression, and that there's this bidirectional link between systemic inflammation and affective symptoms. For example, we can find elevated C reactive protein, IL-6, IL-1, and TNF alpha, both in subsets of RMDs as well as depression. So we know from our experience, these biomarkers are common targets in the treatment of RMDs. So, and some of the biologic DMARDs have actually been investigated for treatment of depression alone, separate from inflammatory conditions like RMDs. But they did find in some of the studies that they are not significantly helpful as a primary
Mm.
target for depression, but that if a patient has comorbid inflammation, then they are definitely more helpful. So there is definitely a link there. The Lutz article also, again, notes that higher levels of CRP and IL-6 predict future depressive symptoms.
Huh.
So when they looked at patients and measured these biomarkers, they could predict 6 months out how they might be doing. So, and then interestingly, the flip side of that is if they had effective antidepressant treatment, the number for CRP and IL-6 would also decrease.
That's wild. Well, so, I think a lot of our patients, we think about first, we probably don't talk about depression enough in our clinics. Do you think that's a role that we should play I don't know if to treat patients with depression, but to like identify patients with depression and then refer them accordingly? Is that something that we should be doing regularly in our rheumatology clinics?
I do think it's important to screen. I work for a federally qualified health clinic, and it is mandatory that we screen
Mm.
with the patient health questionnaire. We start with the PHQ-2. It's just a 2-question survey tool, and then it automatically reflexes to the PHQ-9 to tell us if a patient is severely or moderately or mildly depressed. So I do think that's helpful, and a medical assistant can do that. It's very easy for me to screen in the chart and see, okay, well, what was their score? Is that
Mm.
something that I need to look at? Are they already on an antidepressant? Are they already having counseling sessions? Are they already involved with a counselor, a mental health professional? So I do think that's important for us. And I think most EMR systems now, you can build in survey tools. There's really good tools for both anxiety and depression. There's not really good tools for grief.
Mm.
If you're wondering about, how do I really know? Is my patient having prolonged grief? Is this an abnormal grief response? The typical grief scales are more for the bereavement type of grief. So there's not really a good one that we could utilize in patients with RMDs. There is a grief impairment scale that's a 5-item scale, and it's available in the public domain. And you could use it, but there's really not something out there that I would say really works as well. I think probably one of the best things that we could do is just ask a question.
Mm.
We're already talking to our patients. So a simple screening grief oriented question might be, what have you lost because of your arthritis condition that others
Oh,
may not see?
that's a good question. I don't think
Yeah.
I've ever asked that. I do ask patients often, do you think you're depressed or are you depressed? And, many patients are very honest about it. I think the toughest, you're right. It's like very difficult to first ask those questions, right? The grief questions, depression questions. And I think just as difficult is trying to figure out what to do with it. I think automatically many of us have this reflex like, oh, you need an SSRI, like either let me prescribe you an SSRI or let me refer you to somebody that can prescribe it. What do you think about sort of medications for the treatment of depression? And is there anything else that we could do that would help our patients as well?
Well, I do want to kind of tag onto your comment about we really need to be ready. So if there is a positive screen and they're not on an antidepressant and they're not seeing a counselor, what are we doing? Because then all of a sudden the ball is, on our side, and we
Yeah.
really need to make sure that our patient is taken care of. So definitely establish relationships with your interprofessional team in your community. Know who are your social workers, your counselors, your behavioral health workers that can help you. Also, suicide risk assessment is important as well,
Mm.
and then crisis protocols. So we should definitely be thinking about that. For me, although I work in a rural community and we have very little resources, I am so blessed that we have behavioral health as a part of what we offer our services. So it's a little bit easier for me to actually refer patients in-house. I have counselors on site. So that is a wonderful thing for me. I truly appreciate that. In private practice, I did not have that. So it was much harder to find, is there a provider that's on their insurance? It added another layer of complexity. But I guess to your question, I would say definitely pharmacotherapy. For someone who is depressed, they need some relief. Grief, anxiety, these people need relief. And it is part of our role. I mean, we could argue that, oh, we're practicing rheumatology. We have nothing to do with that. Well, we really do, because it impacts our disease. It impacts the ratings that we do, joint counts, how they're feeling. So, but what I'd like to say is that in addition to pharmacotherapy, lifestyle medicine can offer additional relief for patients. I'll introduce my background includes I'm a social worker. So one of the foundational concepts taught in social work is the saying, give a man a fish and he eats for a day. Teach a man to fish and he eats the rest of his life. This focuses patients on the ability of them to care for themselves.
Hmm.
So, this is another concept in social work about self efficacy or self care, which becomes central to managing any chronic disease. It doesn't matter whether it's inflammatory arthritis or any other chronic disease, patients have to have that agency or self efficacy. So, and if we don't address the whole person, it's hard to fully treat the underlying disease. That's often multifactorial. So we have to have a multifactorial approach as well. It can't just be a pill. I feel like sometimes we can reduce things down to a prescription. Is the whole talk. The whole premise of the title of my talk is beyond the prescription pad. I want to do things for patients that are I'm more than a prescription pad. I've trained a lot of years. I have a lot of experience. I have a lot of things to offer. And it's more than an injection, an infusion, or a pill. So
I love, yeah. At first, I have to highlight how powerful that is. I love that idea. It's like I have a lot of experience. I think there's other things that we can do to help you. And I also like a lot the idea of self-efficacy, right? So that it's not just like I'm the poor patient, my doctor is going to fix me. It's no,
correct.
there are things that are within my control that will help me with my disease, in addition to medications and other things that can be offered by
And
by a doctor.
consider this importantly. I have experienced it myself, so I can speak from this perspective, but burnout in providers. If you are the answer to every patient's problem, that is a lot of stress. That's a lot
Mm,
of burden that's put on you. When your patient is more caring for themselves, that takes a
mm,
lot of pressure off of us. Then it's you joining with the patient as a partner and looking at the problem together. And so both of you can see you have something to give to this problem. You have something that you're working on, but it's from a totally different perspective. So I think that it's important for providers from the standpoint of burnout reduction. So, and I like to say that lifestyle medicine, these are things that you can do on a daily basis that are low risk and generally without significant cost. For me, working in a rural community where poverty is very high, this is critical. I teach patients that we think of lifestyle measures as these wise things that your grandmother might teach you about caring for yourself. So when we talk about reading package ingredients, if you're looking at ultra processed foods, I ask them like, okay, well, take a look at it. Number one, if it's long, it's probably maybe ultra processed. But would your grandmother have these things in her kitchen? Would she
I
be able
lo-
to pronounce these words? Or can you pronounce the words? Or do you know what those are? Would you have them in your kitchen? And so that's a nice tie back to say these are things that are kind of self evident or things that we kind of take for granted that we can do.
Barb, I have to admit, the first time I heard about lifestyle medicine a few years ago, I had this image of like a doctor with a pina colada on the beach. It's like, that's lifestyle medicine. But I've learned, because my wife is also certified as in lifestyle medicine, that it sort of is like all the things that we could do to sort of stay healthy in addition to medications and stuff. I was wondering if you could just introduce our audience to lifestyle medicine, sort of what are the main tenets, and how do you think we can apply those to people with rheumatic diseases?
First and foremost, I agree with you. You hear lifestyle medicine, and even when I went to PA school, one of the first things, if you're treating a chronic disease, the first thing is lifestyle measures. And they never went into detail in school as to what they were, but
Mm,
we were supposed to recommend these lifestyle measures that would be eat less, have more exercise, just general kind of comments that really never help the patient. So lifestyle medicine is very different because it is the medical specialty unto itself. It is evidence based. And I really want to say that twice. It's evidence based. So, everything I'm going to talk about, there's evidence to prove that it is efficacious. Sometimes the barrier to implementing lifestyle medicine is lack of expectation, not
mm,
only from the patient's perspective, but also from us as providers. Like, how could I expect that improving a diet is going to drop someone's hemoglobin A1C, or that simply adding walking into a routine is going to drop their blood pressure? But it really has been proven. So, as far as the American College of Lifestyle Medicine, how they define lifestyle medicine is that it uses therapeutic lifestyle interventions as a primary modality to treat chronic conditions, including, but not limited to, cardiovascular disease, type 2 diabetes, and obesity. So there are tons of research articles providing evidence that we can prevent, we can treat, and we can reverse these diseases, which is very exciting. Dean Ornish, very well known name in lifestyle medicine, recently has published on Alzheimer's disease. And typically we think of there's no reversal for that. And his study has more focused on prevention of Alzheimer's disease.
Mm.
So I think that's very exciting because that provides hope for patients. So
that showed that these lifestyle medicine measures could prevent Alzheimer's?
yes,
Wow.
yes. I'll have to get the actual quote for that or the actual reference for that. But yes, that's true.
Amazing.
Dean Ornish is already well established in his program. It's a program for reversing cardiovascular disease,
Mm.
is already reimbursable through Medicare. It's one of the
Wow.
only programs. So very important to know that we have some evidence-based examples that are ahead of us. So to get to the meat of it, lifestyle medicine focuses on 6 pillars. The first one is a whole food, plant predominant eating pattern. And that's really important. Whole food, and that it's not being ultra processed and it's plant predominant. Physical activity. Notice we did not say exercise. It just says physical activity. Restorative sleep. The key word there is restorative. Stress management. Positive social connections. Of course, this was highly emphasized during the COVID-19 pandemic when we were socially isolated. We became painfully aware of how important that was. And then 6, avoidance of risky substances. That's like smoking, alcohol, drugs, and things like that. So, and all pillars are interconnected. And there's not one pillar that's necessarily more significant or important to address than any other. I think that's important because we all pick out, well, my favorite pillar is nutrition. My favorite pillar is sleep. And it's important to think too where your patient really wants to start. I may think that my patient really needs to start in nutrition, but maybe they really want to work in sleep, or maybe they really want to work in social connections. So I think that's very important as well.
So, Barb, you mentioned sort of the evidence base behind all of these recommendations. Is there any evidence about how these pillars that you mentioned particularly affect people with rheumatic disease?
I think a beautiful study is Wegner's Plants for Joints. This was a randomized control trial for a 4-month program, and they prescribed a whole food plant-based diet for patients. They prescribed activity and they prescribed stress management. And I'm very clear in using the word prescription because we have to start thinking of lifestyle measures as prescriptions.
Oh,
It's not just
interesting.
saying, oh, just eat more apples, or oh, just walk your dog. We're really setting SMART goals with patients. We're really having them monitor themselves. So they looked at 2 groups of patients with arthritis. They looked at patients with rheumatoid arthritis, and they looked at patients that have metabolic syndrome associated osteoarthritis. And they put them in these groups, this 4-month program with diet, activity, and stress management for 4 months. In that 4 months, the people with RA were able to reduce their DOS-28 score by almost 1 point.
Wow.
The people
From diet alone.
from diet, activity, and stress management. So
Oh,
this
for
is
the whole
looking at
thing.
3 pillars. Yeah,
Yeah.
3 pillars within lifestyle medicine. For the patients with osteoarthritis, they improved the WOMAC scores by 11 points.
Wow.
And then they did a 1-year extension study that showed that the benefits and adherence were largely sustained at 1 year. It was more sustainable in the RA group than the OA group. But, this is a very powerful study, and they've published multiple papers about it. But I think we should sit up and take notice that we have to get more serious in rheumatology about including these kind of lifestyle medicine measures in how we treat patients. And we really need to be prescribing them.
Super interesting because, I can think of many patients that with RA that are on maximal medication therapy and they're still not in remission. And I always think, well, what else could we add? Could we add yet another immunosuppressant, like double biologic therapy? But this seems like a much safer and still very efficacious way of managing RA with, like you mentioned, plant-based diet, increased activity, and stress management. What do you tell patients when you say, oh, whole foods, plant-based diet, or what do you tell them when you recommend increased activity, or how do you encourage them to manage their stress? Like, what are the actual tools and prescriptions that you're going to give your patients?
I'm going to pull in another thought on the title of Beyond the Prescription Pad. And I'm going to say, let's flip the script.
Okay.
Okay. And the script is the prescription. So we already talked about I need to be prescribing lifestyle medicine. But what if we flip the script and really do something differently and really ask the patient first? It's very easy. I'm very comfortable with being the expert and telling my patient where I think they should start. But we really have to take a step back and really use more of the coach approach, or even start integrating more motivational interviewing, because we are really partners in the work that they do. And we may think, well, I don't have time to do that. But as you just suggested, you have a patient that's on maximal therapy. What else are you going to do? Lifestyle medicine is looking pretty good because
Yeah.
we have to take a step back and look, okay, how are they sleeping? Is there some unmet or untreated depression there? We definitely have to take a look at that. There are articles identifying that the patients that are most successful at making these behavioral health changes are patients that are kind of consulted. We co create goals together, and they really need to be SMART goals. These are SMART goals that you would find in any other business application or other places. SMART goals stand for specific, measurable, achievable, relevant, and time based. And then also including this aspect of self monitoring. Patients, then you're putting the patient in that primary responsibility of,
Mm.
I'm going to come back and we're going to talk about this particular thing, whether it's how I'm eating or how much activity I have. So you can see how this approach takes the focus off of the provider to provide a pill for each symptom or concern and places the control, or in social work terms, it empowers patients via modifiable lifestyle risk factors to take control, again, self-efficacy of their health. I don't think any of us like to be told what to do. I'd much rather have a partner or a coach that comes alongside me and encourages me to achieve things on my own.
Let's role play a little bit about how this would actually take place in a clinic. So let's say that my RA is not well controlled. How are you going to coach me to like choose one of these pillars and try to get some smart goals to improve my health?
I have the lifestyle medicine wheel on my wall, and it kind of shows you, it's a very nice, attractive wheel with the pillars on there. And I kind of walk through the pillars and say, how would you rate yourself? Which area do you think is the lowest rating for you? Is there
Hmm.
one that you would prefer to work on? That's kind of how I do it.
Oh, fascinating. I like that. Yeah. So you sort of give them a menu and have them choose instead of you choosing for them. Like you
Correct.
said, if
I
they,
think that's critical. I may think that they need to stop smoking, but maybe they're not ready for that right now. And that can lead to more frustration for me as a provider. It's easier to start where the patient wants to start. And once they have a little bit of success, then it's easier to move on to something else that may be more successful.
yeah. Yeah.
So I think that's key and critical.
Yeah, and the diet aspect, I think more and more there's data about the role of diet. I know the recent ACR guidelines sort of conditionally recommend like a Mediterranean style diet for patients with rheumatoid arthritis, so that makes sense. I wonder what, in patients that have challenges with sleep, what are some of the recommendations that you provide them with? Because, patients that don't sleep well, they have difficulty falling asleep or they wake up frequently. How are you counseling them to help them improve their sleep?
Yeah, I there's an article by Adamir that studied, early RA and 502 patients that found that sleep disturbance predicted greater pain interference 6 months later, and independent of confounders. So I think this is really important to do a
Wow.
really good review of how they're sleeping. The first thing I would do they have risk factors for obstructive sleep apnea? If they do, can we refer them for a sleep study? And then looking at sleep hygiene, there's some very good handouts on sleep hygiene. And I think with technology these days, we are so inundated. It's very hard for us to turn off our phones, turn off our computer screens. So those are the top things and other sleep hygiene techniques. There are also, for any providers that are interested, there are two excellent books. One is by Matthew Walker, and it is called
Like why we sleep? or
Why
something
We
like that.
Sleep. Yes,
Yeah.
Matthew Walker, Why We Sleep. And he does like an interesting review of the history of sleep, not only in humans, but in other species. And he really makes a powerful discussion of how important sleep is. After reading that book, I apologized to my son, who's now in college, but when he was growing up, they had to start school early. And as a mom, I would be like, you've got to be up. And even on the weekends, if we had something to go to, you've got to be awake. And I've actually apologized to my son to say, I am so sorry that I cut your sleep short because it is your superpower. And I think convincing patients that it really is their superpower and then educating them that your immune system is resetting itself or recalculating while you're sleeping. And there's lots of evidence looking at the brain and when does the brain clean itself? When
Hmm.
does the gut clean itself? That downtime, I used to think of sleep as wasted time. I so after reading these books, I am a convert and sleep is my superpower. I'm a much happier person now. And if you asked me my opinion on what is the most important lifestyle medicine pillar, I would definitely say sleep. Because if I don't sleep, I cannot make healthy food choices. If I don't sleep, I don't have the energy to exercise. If I don't sleep, I don't have the mental capacity for creativity that's required at my job. I don't have the psychological resilience to be kind to my children, my family, my coworkers. So sleep, I think talking about how important it is, and it is not a waste of time because this is when your body repairs itself. I just had a patient in recently with lupus and she's kind of in the beginning phase and we're starting treatment for her. And she stated that she's only getting 5 to 6 hours of sleep per
Hmm.
night. And just by me saying, this is really important, she has young children. And I said, is there any way that you can talk to your family at home and talk to your husband? And certainly she said, at the end, she said, I am definitely going to talk to my husband and tell him that you said that I really do need around 7 to 9 hours of sleep per night. And I thought just having that conversation opens the door and just opens their mind to think, wow. And this was a problem that she brought up. I wasn't asking about sleep. She let me know that she was not sleeping, that she was getting fewer sleep hours.
Yes.
So
I think fatigue is a huge complaint among people with rheumatic and musculoskeletal diseases, and poor sleep may be one of the leading causes of the fatigue. So I totally agree with you about the importance of trying to improve sleep. We just had our grand rounds today mention that I think disturbed sleep can actually be an inflammatory trigger. And therefore, if you get better sleep, you don't have that extra inflammation and may even help disease control.
it's very true. In rheumatology, we have to really screen or do a review of systems for really every organ system. And so it's definitely within our wheelhouse. We need to know how our patients are sleeping because their immune system is not regenerating or it's not resetting if they're not getting that sleep. So definitely extremely important and really does have impact for disease activity.
Yeah, and let's switch gears a little bit and talk about physical activity. So it's not exercise, but physical activity, I guess, encompassing many other things that aren't like traditional exercise. What are the sort of things that you may recommend patients if you're trying to get them to increase their physical activity?
Like sleep, I would emphasize encouraging patients that we have studies, specifically in arthritis and rheumatic conditions, that prove that exercise helps with function, pain, quality of life, anxiety, strength, and cardiorespiratory fitness. So there are multiple reasons to increase your activity. There's low risk of side effects. The side effects are good. It helps your heart, it helps your brain, it's cost effective. You don't have to have expensive gym memberships. We're just talking about movement. So we have to ask them to move more. In the studies that were looked at, they looked at walking, jogging, yoga, resistance training, especially working with an older population in the adult population as I work. We really have to look at muscle strength. And muscle strength or muscle mass is kind of equivalent to thinking about brain activity. So
Hmm.
I use that a lot to tell patients when you're making your muscles stronger, you're making your brain stronger. If you want to live independently longer, that's super important. So resistance training, balance training, I refer a lot for occupational therapy for the hands and physical therapy in general. I have patients walk. I watch them get out of their chair. If they use their upper extremities to lift themselves out of the chair, that's an immediate referral for me if they're agreeable for physical therapy. And I have had patients come back and thank me for making that referral. And I also talk about with patients, especially as they're elderly, just as you would do an annual check for your car, annual PT evaluation, just so that those concepts don't get stale in their mind. And I think it provides patients another coping strategy. Again, dealing with that grief. If the grief is around loss of function, how can I help them regain some of that function or think differently about the things that they're doing? How can they use different tools or other assistive devices to help them deal with that?
Barb, and before you mentioned that it seems like the whole lifestyle medicine approach, not only is it helping you help your patient, but it's helping you as well. I'm wondering if you could talk more about sort of the benefit of learning about lifestyle medicine for ourselves and for our well being.
Great point. I did want to say that activity, and I'm going to use the word exercise here because in the studies that were looked at for exercise, it is effective for depression. So I'll say it again that exercise is found to be effective for treatment of depression. Now, you can use it alone or you can use it in conjunction with pharmacotherapy, but that is a very strong statement to make and can be very convincing if you're talking to
Wow.
patients to say, look, we're looking at a couple of different strategies here. But in regards to us as providers, have you heard the airline admonition that says, should the cabin experience a sudden loss of pressure, oxygen masks will drop from the ceiling? And John, I want you to fill in this word place the mask.
On yourself first before helping others.
That's right. And so that's what lifestyle
Mm,
medicine, that's how it helps us flip the script also, is that we're not writing a prescription just for our patients, we're writing a prescription for ourselves. And so self care comes first.
hmm.
Clinician health enables us to take better care of our patients. I'm better able to care for my patients when I'm mentally, physically, and emotionally healthy. I don't know if you've heard of the book by Stephen Covey, The 7 Habits of Highly
Of
Effective People.
course.
Yeah. So the seventh habit, if you don't know, is called sharpen the saw. And what is the saw? The saw is us. So the more time that
Mm,
we take to sharpen ourselves, the easier it is for us to be effective. So to me, lifestyle medicine just embodies this concept. The other is burnout reduction. And there is a
mm,
study by Pollard in 2023 looking at practitioners that implemented lifestyle medicine. The greater proportion of lifestyle medicine that they implemented was associated with less burnout. And they attributed that to providers feeling that there was more accomplishment when patients came back and told them, hey, I'm doing better on this or I'm doing better on that. They also noticed less depersonalization. So, as a provider, I felt more connected with my patients. So, it kind of is a reflection of that therapeutic relationship that we're building with our patients. It has the power to impact patient related outcomes.
super interesting. And Barb, for listeners out there that are interested in learning more about lifestyle medicine, where should they go? And also, what is required to become a sort of a board certified or a diplomat in the American Board of Lifestyle Medicine? What's the process that you need to go through?
The best place to go is the website American College of Lifestyle Medicine. That's the best place to go. Currently, for any listeners that are working in the underserved areas, like myself, if you're working at a federally qualified health center, they are offering scholarships that are worth or valued at $3,500.
Wow.
And that pays for 1 year of membership in the American College of Lifestyle Medicine. It pays for your board exam, which is expensive, as we all know. It pays for some board review materials. So to me, that is a wonderful deal. So I encourage anyone to go there. As far as board certification, it's a little bit different for healthcare professionals versus physicians. There is an exam that you have to take. There are requirements regarding CME. Some of it absolutely has to be in person. So they really want to encourage that social connection and being on site and learning lifestyle medicine information. And then there's also maintenance of certification that once you're certified, you have to continue to do that as well. So it's very much standardized like other certification programs for other specialties.
Yeah, I mean, I think the thing that I guess you don't have to do is yet another fellowship, right? So you could do this while you're in training, you can do this while you're practicing. You don't have to stop what you're doing. You can sort of do these things on the evenings and learn about lifestyle medicine, eventually take your boards, become certified.
Correct. There's no residency or fellowship or anything like that. There's not anything specific regarding that. And it really does help you from the standpoint of applying the concepts to yourself. So as you're learning these things, you're thinking for yourself. So it really does help you. There are, in addition, some programs. I'm in a doctoral program right now, a doctorate of medical science that has a lifestyle medicine track.
Hmm.
So we have noticed that there are maybe about 4 DMSc or doctorate of medical science programs that are offering lifestyle medicine tracks for PAs. So I
Wow.
think that's very exciting.
That's amazing. And that's right. You don't have to be a physician to become certified.
Correct. You could be a
Amazing.
nutritionist, you could be a social worker. Yeah,
Amazing.
any interprofessional.
Great. So Barb, wrapping this up, what do you hope that the future of rheumatology care looks like with trying to integrate lifestyle medicine within our clinics? What would you hope that providers and patients get out of this?
I really hope that it looks like a village, that it looks like a community, that we really recognize that it's not just on the provider's shoulders to prescribe a medicine, that there are all these other interconnected health professionals that play a role in making sure that we as individuals stay healthy, but that in our community that we stay healthy. So that's how it looks to me. I think also it looks at making sure that at the educational level, either in medical schools or in PA schools or nurse practitioners or pharmacy schools, wherever, that we're looking at lifestyle medicine. We really don't teach enough of these concepts, and it's really a shame that we don't. So I hope that we're starting to integrate some of that, even within rheumatology, and even the fact that we're seeing a topic like this presented at Convergence, I think echoes the importance.
Absolutely. And I hope that more and more listeners out there learn about lifestyle medicine and become involved and maybe even become sort of certified or board certified. Because I think from what I've seen with my wife, who's, as I mentioned, is also certified, she's taking a lot of those things and implementing it in our family. So we're like trying to eat better, more plant-based diet, certainly focusing on sleep. So all of us are trying to get to bed early and physical activity where we're certainly trying to do that as
You bring
well.
up an excellent point that I also want to say that is a benefit for us as providers. When I'm implementing these strategies in my own life, I speak to patients with experience. And I can say, I struggled with this, or this didn't work for me, or for me, I do this. And we're not saying that everybody has to follow that, but the studies have shown if I am implementing these lifestyle measures, I am more likely to encourage them in my patient. If I'm practicing yoga and meditation, I'm more likely to talk about those things with my patients. If I'm a runner, I'm more likely to talk about running. So, I mean, it's very true. So, I'm glad that your wife is implementing that at home. That makes her more effective, I think, as a provider. But look at the benefit, look at the ripple wave to you and probably to your patients. But then look at your children and maybe the ripple in their community. So it's very powerful.
Love it. That's a great way to end, Barb. Thank you so much for your time, for all the work that you do on behalf of patients. And I look forward to your chat at this year's Convergence.
Thanks so much, John.
What I love about Barbara's framing is that it collapses the distance between the doctor and the patient, between the prescriber and the prescribed. Lifestyle medicine isn't just about veggies and steps and sleep hygiene. It's about reclaiming agency in systems that have stripped it away from us. If you want to learn more, please listen to Barbara's talk, Beyond the Prescription Pad, Assessing and Addressing Grief and Depression Utilizing Lifestyle Medicine. She'll be presenting her talk on Sunday, October 26th at this year's Convergence. You can check it out live or find the recording from the ACR Convergence 2025 program on demand. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, think about what your prescription pad might look like if it included compassion, sleep, food that heals, and of course, stay healthy. Here at ACR On Air, we'd like to take a moment to thank Pfizer, the sponsor of this podcast episode. Their dedication to research and collaboration with the ACR and the field of rheumatology has been essential to improving the lives of those impacted by rheumatic diseases. To find out more, visit Pfizer.com.